Good morning, everyone, and welcome back to the Med-Tech Innovation Conference stage here at Med-Tech Innovation Expo. We are delighted to introduce our Day 2 keynote session from Johnson Johnson MedTech and Barts Health NHS Trust. Gianluca Casali and Paul Bhogal will be discussing changing the trajectory of stroke through industry partnership. So, without further ado, because it's not me you want to hear from, I'll let Paul and Gianluca take the lead.
Very good morning, everyone. Thank you for coming, first of all. I like to do a quick poll to try to understand who is sitting in the audience. Okay, so I have one group is physicians, surgeons, people working. One, great. Med-tech industry, and then somebody else. Okay. Fantastic, fantastic. Good, good, good. So this is just to have a sense from where we start. So we will give a very quick overview on stroke, and then we will travel through the hurdle that we have in the NHS to treat patients on time. We will look at innovations, how we innovate, and we will really welcome questions and interaction. So if at any point we are too technical, please say, okay, I want to know a little bit more about this because I'm lost here. And we don't want to lose anyone. We want to reach the end of the conversation together. Fantastic. So, Paul, would you like to introduce yourself?
Sure. Okay, that's working. My name is Paul. I'm a consultant interventional neuroradiologist based at the Royal London Hospital. I trained and did all of my training in the UK at UCL for undergrad, then in and around London. Then I went and worked in Sweden and subsequently worked in Germany before returning to the UK. I'm a co-founder of a couple of companies, and I'm also the director of what I call Brain Conference, which we can discuss at a later stage. And I'm the research and mechanical thrombectomy network lead at the Royal London Hospital. So basically, this is going to be, I think, about how we've changed the trajectory, but realistically altered the outcome of hundreds of patients and hopefully soon thousands of patients having strokes from essentially the whole of the southeast of England. So a gigantic geographical area.
Fantastic, Paul. Would you like to give a just quick overview on stroke and what is the situation in the UK?
Sure. So most of you probably have heard of a stroke. There are essentially two different types of stroke. One is hemorrhagic, so that's a bleed into the brain or a bleed around the brain. The other one, which is much more common, is what's called ischemic, and that's typically caused by a blockage in the blood vessel of the brain. The latter accounts for about 80 to 85% of strokes, okay, in total. About 10% of those, we think at the moment, although it might be higher, are caused by what is called a large vessel occlusion. So not a distal, tiny little blood vessel, but one of the big blood vessels at the base of your brain or in the neck going up into the brain that affects basically a very large territory of the brain. So obviously you could imagine that one of these big blood vessels being blocked could damage a very large amount of brain, and then that will significantly impact your ability to do all kinds of things: talk, read, understand, move, emotional, everything gets affected. So that's a little bit of the types of stroke. Now, up until 2015, the only real treatment option that was backed by randomized controlled trials was thrombolysis, so a drug that would fragment the clot. But we knew even at that stage, and we've known for a long time, that not all clots break down with thrombolysis, and that is dependent on many different factors. So in the run-up to 2015, sort of 2012, 2013, 2014, people started actually using small devices called stent retrievers, a stent on a long wire that you would deploy temporarily at the position of the clot, leave for a few minutes, and then you would pull the stent out, and you would pull the stent, and hopefully the stent has grabbed onto the clot. And that's actually what was happening. So in 2015, 5 trials were published from all around the world demonstrating significant improvements in outcomes of patients. This is functional outcomes, not pictures and things like this, but actual functional improvements by pulling out the blood clots. And importantly, these patients had also had thrombolytics. So it wasn't like the thrombolytic wasn't working. Well, it wasn't working. But these people had thrombolysis, they were getting the best standard of care, and then on top, having the mechanical thrombectomy. So as an adjunct.
Paul, can I just stop you 1 second, because we were chatting before, and you were talking about patients given thrombolysis, unable to leave the table, and then?
So yeah, I mean, this is the interesting thing. Prior to the randomized controlled trials, I was doing mechanical thrombectomy in Sweden in 2013, 2014. My former boss, Professor Henkes in Germany, is widely credited as being the first person ever to do a mechanical thrombectomy with a stent retriever. That was back in something like 2007, 2008. So people outside of the UK had been doing these procedures prior to the randomized controlled trials. And many of these people were saying, look, we will pull out the clot, and 10 seconds later, the patient is talking to me, is moving their leg that was paralyzed beforehand.
So it is the brain that was going to die.
Yes.
And
Has
removing the clot, blood start flowing,
yeah.
Brain restart working,
yeah.
and patients can restart moving.
Yep. I mean, I'll give you an example of one of the things that we've managed to do recently in our hospital. Was a relatively young man, he was I think about 60, was in the pub having a pint, had a stroke, came into hospital, and within 60 minutes from him presenting to our hospital, he had gone through the CT scanners, I'd made the decision to do the procedure, we'd got him into the lab, and I'd pulled out the clot. And at the end of the procedure, this is all in sub 60 minutes, at the end of the procedure, I asked him to sign an agreement for research, which he agreed to, but he signed it using his paralyzed hand.
Or not anymore paralyzed.
Not anymore. and the funny thing was he said, oh, I can use my hand again. And I said, you better sign the research agreement then, better than you. So it's all of these sorts of little things, and that's not a rare occurrence. That happens routinely. Patients will start moving a few minutes afterwards, 24 hours afterwards.
And a stroke is not a rare occurrence.
No, unfortunately not. It's we in year one when I was in the Royal London, we were doing maybe about 60 of these procedures. Now we're on target for well over 300. And that's in like 2 or 3 years.
And to give a sense, Paul, so if you look at the Royal London, what is the area that it covers at the moment? What is the population that you cover?
I think we take patients from like Czech Republic, like Norway. Sometimes they fly over from further afield. But in all seriousness, we basically cover a massive geographical area. We cover the whole of Kent for mechanical thrombectomy, the whole of Essex, Norfolk, parts of Suffolk sometimes as well, I think, Sussex sometimes. So we'll take patients from Peterborough, Norfolk and Norwich, all of the east coast, all the way up to the east coast of Kent, all of East London. So I think in total, the population that we're covering is something like 8 million people. Like it's huge. And so from our perspective, the number of people that we're going to be treating is only going to go up. The limitations on how many people we can treat is effectively, how many of us there are, access to the rooms, how quickly we can get the patients to us, all of these sorts of things.
So two important things. So first, I think it is worth giving, what is the opportunity window?
Yeah.
If you have a stroke, how long before you lose completely the opportunity to have a good treatment? Because that, I think, is one element. And the other element is what you are describing is probably not what is happening all over in the UK.
No, unfortunately not. So I'm going to just ask for a little bit of interaction, if that's okay. So how many of you think that the vast majority of people who've had a stroke, there's nothing to save, let's say, beyond 6 hours? Put your hands up. Okay. Okay, fine. Nothing to save beyond 12 hours? Okay, so probably about half the audience thinks up to 12 hours there's something to save. Beyond 24 hours, you think there's still something to save? Okay, so the truth is you're kind of all correct. Because what you have to realize, and this is where the constant education, the constant research, all of these things feed into one another. When I was at med school, essentially we were taught, once you've had a stroke, that's it, like it's all gone, blah, 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 which is not actually the truth in many patients. In some patients, within an hour, that's it. There's literally nothing to save. The stroke is what's called a rapid progressor. And in other patients, even beyond 24 hours, actually, the patient's got very good collateral circulation that is reaching around and supplying the brain. So if you open the blockage that's there and get normal flow back, actually you have a very large territory to save. So that person's called a slow progressor. And, you know, like with a Gaussian curve, most people are kind of somewhere in the middle. So you still want everything to go as fast as possible so that you can save as much brain tissue as you can, which then will improve the likelihood of you having a good functional outcome at 24 hours, 3 months, 1 year, get you back to independent living. So move as fast as you can, but don't discount someone if their symptoms have been there for, let's say, 6 hours. Get them into the CT scanner, move quickly, do all of the imaging, get onto the phone to us, yes, no, maybe.
But your ideal situation would be to have a patient as soon as possible.
Absolutely.
So would you say less than 4 hours?
I would say that don't bother putting a time on it. Like, think of this as like, you know, the F1 racing drivers changing the wheel. You have to do everything as fast as you can. Look for those little 1% gains wherever you can get them, not just in your site, but in other sites. Contact people, speak to people, constant iteration, because the evidence is always changing as well. Like, almost every 3 months there's a new trial, like some sort of device or some new additional medication, some new position within the brain of where you can do stroke thrombectomy, all of these sorts of things. So, you know, just you have to have this mindset of, I'm not fixed here. I'm constantly looking for how can I get a little bit better? And then you're always looking for the little 1% gains.
Fine.
What determines whether someone's a slow or a rapid progressor?
Yeah, so that's a really good question. So essentially, I'm trying to think of the best way to describe this. You, in your brain and actually in your body, you have what are called collateral circulatory pathways, so the collateral circulation. So one of your blood vessels, a big one, it comes like up in the middle and it will go out. So it will go laterally over the surface of your brain and go like this. Another one of them kind of comes into the middle and supplies this sort of middle strip, right? But if this vessel coming out gets blocked, in many patients, this one can actually reach around and start to take over the same territory, right? So that's the collateral pathway. Now, we don't really know why some people have very good collaterals and some people have essentially zero collaterals. And it is that breadth of range. Some people, almost nothing. You can't see anything. You do the angiogram and you think, oh, it's too late. But most people actually have quite good, or they have some sort of collateral network that allows the preservation of the brain. The problem is that collateral network decays over time. Hence why you still have to move quickly. Even if you've got good collaterals, they can't sustain the brain essentially indefinitely. Over time, over hours, they start to essentially weaken and collapse. And that's probably an exponential decay, actually. Does that make sense? Okay.
Thank you. So, well, just to continue that point, so if you've done a CT and you know they don't have a hemorrhagic stroke,
Yep.
Is there room to give them vasodilators to improve the collateral?
So this is a good question. The problem potentially with vasodilators is there's two things. Number one, the collaterals may well have already dilated maximally. We don't know. Number two, there is no cerebral specific vasodilator. So part of the thing that drives your collaterals is your blood pressure. So if you lower the blood pressure, which is what vasodilators will do, you will also collapse the collaterals. So you're kind of potentially half right. If we could have a very cerebral collateral specific vasodilator, it would probably work, but we don't have that. Well, yeah, we don't really have that.
Any other question? Are we okay? Yeah? Fantastic. Good. So, speed, as soon as possible, F1 race, change of tire, that is what we want. Treatment as soon as possible is thrombolysis, assuming that is not an hemorrhagic stroke, and then the more advanced and more recent technology that is stroke thrombectomy.
Yep.
What is the state of the art at the moment in stroke thrombectomy? It's available everywhere, everybody gets access. If I have a stroke here?
Here at this time,
if
probably.
I have a stroke in an average city rather than Birmingham, so we avoid.
So unfortunately, we don't have 24/7 full geographical cover in the United Kingdom as of yet. And I think this is still, unfortunately, several years away. And this is in large part due to funding streams, in my opinion, and pathways not being set up. We've done lots of good work in our region and extended region to cover Kent and the other places. And London is very well served, I would say. Now you're starting to see similar excellent improvements in and around Bristol, for example, Liverpool. Birmingham is moving towards 24/7. Cambridge hopefully will be up and running sort of in the next 6 to 12 months with 24/7 mechanical thrombectomy. But certainly there is still, quite a lot of work to be done. And I think, for example, if you're in Wales, if you're in the deepest, darkest parts of Wales, you're not going to be near a hospital, let alone a hospital that's got mechanical thrombectomy. So you have to look at these sort of supra-regional pathways, working with your sort of acute stroke units and those sort of providers, using the established networks that exist, and optimizing the transfer of the patients to mechanical thrombectomy capable centers. That's all going to take time, and it's happening. It'd be nice if it happened a bit faster, but funding is one of the main problems, I would say.
I suppose the challenge is also on that you're treating patients coming from a broad geographical area where the connection between the different elements from diagnosis to treatment is essential. So it is the pathway. Do you want to expand a bit on that?
Sure. So the typical pathway that patients go through at the moment is essentially someone has a stroke in wherever. Ambulance comes to collect them. They are assessed by the paramedics, think they're having a stroke. They go to their local, what's called acute stroke center or primary stroke center. Primary stroke centers have access to CT scans, to potentially, hopefully, advanced imaging, CT angiography, and maybe CT perfusion. And they can deliver thrombolysis, so they can give the drug, right? From there, if the patient is eligible for mechanical thrombectomy, or you think that they're eligible, you have to, for example, I have to look at the imaging, speak with my stroke doctor speaks to the local stroke doctor, and then the patient is transferred from that primary stroke center to the comprehensive stroke center, which is us that can do mechanical thrombectomy and deliver thrombolysis. So it's a sort of multi-stage process. And because of this is where the inherent delays come in. So this is where, like I mentioned, the sort of the 1% gains. If you can get the imaging done fast in the primary stroke center, and you've got AI assistance. So we use AI stroke detection software called Brainomics. Now, for me, the advantage is that I can look at the scan on my phone. I don't have to be sat at home waiting for the images to be transferred. I can live my life when I'm on call. I can be at the gym, whatever I'm doing. Then I can get the call. I can look at the images immediately. And in fact, in some cases, I've seen the images before I've received the call and then thought, I'm pretty sure I'm going to get a call about this patient. And lo and behold, I get the call 10 minutes later. I can make the decision very quickly, which means that they can get the patient to us faster. And so we've actually already done an analysis, Gianluca, where we looked at AI-enabled and AI non-enabled centres. And those were geographically, because of the area that we cover, those were geographically roughly equidistant, actually, from our hospital. And we showed that the fact that if you're using AI, the door in, door out time, so the door in for the patient to leaving that initial hospital was it was statistically significantly shorter. And I think, if I remember correctly, it was nearly an hour shorter. So that is a huge
when you say AI, is you do a CT scan of the brain with contrast, and that gets analyzed by a software.
Yep.
And the software identify area, ischemic area.
Yep, that's right.
Okay. So does it remove the need for an experienced radiologist?
No, absolutely not. So all of these things are they're additional tools, and the companies themselves say, look, this is a decision support tool. It's not to replace. And the reason is there's always things that can fool the AI, just like the doctor can be fooled as well. And so the AI, it's important for everybody to understand that AI in medicine, at least in my experience, it does different things for different people. So for me, the AI doesn't necessarily add very much, because I can see the stroke very well. I've trained to look at that. I can see where the blockage is. I'm trained to look for that. What AI in this instance offers me is the rapid ability to share images. So it's almost, within 5 minutes, the AI is sharing the images. The image exchange portal, which is the NHS classic way of sharing images, it's not designed for this, takes hours, is literally pointless in an acute scenario. But the AI, let's say for the more junior stroke doctor, not quite sure what they're looking at, the changes are very subtle. Sometimes it just gives them that little nudge, that extra bit of confidence to say, pick up the phone to your boss, they won't get angry with you, blah, 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 blah. And so it does different things for different people. And that's the importance, I think, of when talking to people about AI, whether it's MPs, whether it's clinicians, whether it's whoever it is, you have to understand the individual benefits that AI and all of these things actually offer.
So it to me is interesting, because we have an acute event that needs to be treated as quickly as possible. There is a complex pathway. There are different elements that contribute to the success. So yes, you have one device at one point. You need to use the right device, know how to use it. But the effectiveness of that device starts, and it depends on how quick the patient flows. The complexity is sometimes is very human around communication.
Yep.
Yeah, organizing the ambulance, having the helicopter that transport the patients. And I was talking with one of Paul's colleagues, and we were discussing how quickly, can you use helicopter? Yes, of course. But every time the helicopter attempt to land on our hospital, our own trauma helicopter need to take off. So you have the cost of an helicopter taking off for just to leave room to the other helicopter to land. And it seems, from a clinician working in a different area, or a patient, or a politician, or healthcare, you don't really get all this complexity. Exactly. And the amount of communication that needs to flow. The other element I think that is important is you realize that the success of a stroke treatment is not linked to one individual, one unit, one specialty, but is a complex cooperation of many groups. And so Johnson & Johnson, we have worked together for a while, and I love for you to share how do you think industry can help, not necessarily Johnson & Johnson. Johnson & Johnson is just one of the examples.
So thanks, Gianluca, and it was honestly it was very nice to work with Johnson & Johnson. So for anyone that doesn't know, Johnson & Johnson, Cerenovus, their neuro division, they produce some fantastic kit, particularly for mechanical thrombectomy, actually. So novel devices that make it's going to sound really bizarre if you've never done this, but they just make the procedure feel nicer, feel easier to do compared to some of the other kit. Which actually, when it's 3 o'clock in the morning and it's like your 7th one, you kind of want it to be easy. You don't want it to be challenging. But
they are a little bit like, when you have the plumber coming because your pipe is not actually working, they stick something in and scrape it back and forward until they remove. That is what they do, but in a much more elaborate.
I think plumbers make more money than we do. That's the main thing. That's the main difference, actually. But no, so So we partnered with Johnson Johnson. I'd obviously worked with them and actually the engineers back when I was in Sweden. And so I knew how good the kit was. But beyond that, we were working with you to look at this sort of analysis and do some like consultancy work on the pathways and where the little 1% gains could be made. And so, you know, if we all work together, and I hate these sorts of cliches, but if you all work together, you learn a lot from one another. Like the Johnson Johnson guys have been in centers that have been delivering mechanical thrombectomy, and not just mechanical thrombectomy. This is not a unique pathway. You know, trauma is very similar. Cardiac is very similar. There's learning that can come from similar pathways, but we have a tendency to think in silos. And the beauty of companies is that they aren't really siloed. They're seeing this not just in the NHS, not just in stroke, but also in cardiac, which has been around for 30-odd years. They're seeing it in trauma. They're seeing it in Sweden. They're seeing it in France. They're seeing it in Germany. So as the UK, if you're coming to it a little bit late, that's both a disadvantage but also an advantage, because you can learn from everybody else. If you do partner with organizations and you say, well, how are they doing it there? Are they similar to the UK? And what challenges do they face? And this is how they overcame them, and blah, blah, blah. So I think there's a lot to be said for sort of industry partnerships and just starting the conversations, even if nothing comes of it. Have the conversation is, in my, you know.
Some of the knowledge to optimize pathway is quite agnostic.
Yeah.
Yeah. So because the complexity doesn't really matter if it's a product flowing on a product line or actually a patient's moving along a pathway. The complexity is similar, and the technology and expertise that we use is fished out from industry, where effectiveness and speed is essential.
Process optimization.
Process optimization, exactly. And then we apply it to the healthcare sector that clearly has additional complexity. You are not just moving pieces of metal or plastics, you have patients, families, and physicians. But then that area is optimizing communication, and some of it is ensuring that people know each other. So it's as simple as I know the person that I need to refer the patient to because he came to me and explained how these things work. And now I feel comfortable to raise the phone and call. I feel comfortable independently if I'm a junior doctor because I know the consultant is actually quite accessible. And I think all these things that as a company we recognize, because we optimize pathway in trauma, we optimize patients in different area. And stroke, I see it as the perfect opportunity to help, because also the cycle is very, very quick. So you implement something, you see the results almost immediately. You know exactly if the pathway gets shorter in a very short period of time or not. Cancer pathway is more difficult to see differences because the difference that you see 5 years down the line. You look at 5-year survival. Strokes, you know almost in 24 hours if what you did was good or actually wasn't, or exactly the same. And this is fantastic. And then there is another thing that I want to touch, Paul. You love brain, but brain means something different to you as well.
Oh yeah. So just before I jump to this topic, one of the other things that I'd like to say, because I mentioned siloed thinking, one of the next thrombectomies that's going to be coming actually is pulmonary embolus thrombectomy, right? It's essentially the same, just done with bigger equipment and done in the lungs. And I'm talking to one of my colleagues who's trying to set this up, and I said, you should just look at what we did. Look at what we did and essentially piggyback on what we did, iterate it for your own slight nuances, but essentially it's the same. It's an acute problem. You want to get the clot out as fast as you can. You have a complex chain of events because not all of the PEs come to your local center. So look at what we did. Speak to the companies, speak to all of these people, et cetera, et cetera. So we love to put things in silos, but sometimes that's really bad for our patients and just maybe for ourselves as well. Now, coming back to brain, so brain for me is, in addition to obviously the thing, I actually organized a conference. I set up a conference, and this I hope is the QR code that will take you to...
I hope as well is the right QR code.
The website. But as part of this sort of ongoing hope to improve things, not just for neurointervention and for stroke patients and aneurysm patients and things like that in the UK, but actually in the world. I set up a conference called BRAIN, and that stands for Barts Research and Advanced Interventional Neuroradiology. BRAIN's a lot easier than that. And every year, we started this during COVID, and I would like to point out that the work that we did at the Royal London to develop the stroke network, we did this during COVID. We, in large part, set it up because we knew that COVID caused patients to have strokes. So we said, let's reach out to these hospitals and we'll do the best that we can to help these patients, okay? So if we can do that during COVID and go from essentially, 90-ish thrombectomies to an AI-enabled supra-regional network that's the largest in the country with essentially very little infrastructure, well, zero infrastructure spend, effectively, during a pandemic, plus be the largest publishing site in the country and develop an internationally renowned conference, what's stopping everybody else? Like, there's only so many excuses people can fall back on. Now, BRAIN was designed to assist in that change. One of the things that we've spoken about sometimes is that you can get tired, you can get bogged down, there's so many things to do as a consultant, and sometimes that feeling, that inertia, you pass that on inadvertently to the juniors. And if you do that, you really start to degrade systems. The system starts to break down at a very basic level. So if you want to do the opposite, if you want to empower people, the young people have to come and think that they're part of a greater story. How can I, when I become a junior consultant or even as a registrar, how can I get involved with interesting research? How can I start talking to companies to say, hey, you've got something cool, how do I partner with you? How do I set this service up at my hospital, wherever I go? Or I've got an idea myself, and what do I do? How do I go about filing for IP? How do I protect the idea? How do I raise money? How do I get going? And so BRAIN was designed to assist with all of those things and to bring some of the best minds in interventional neuro, but again, not just interventional neuro because that's too siloed, stroke, hematology, infectious diseases, cancers, all of these sorts of things to say, look, come, maybe let's just start a conversation. And maybe for, personally, I think one of the next boundaries for us will be the direct delivery of chemotherapies to the brain after you open the blood-brain barrier. You'll get much, much, much higher doses. It's already being done. It's already been shown to be safe. We haven't had a breakthrough in some of the brain cancers for the last 30 years. These are universally mortal. They will kill 100% of the patients in a very short period of time. I know this for a fact. My dad had a pontine glioblastoma. So maybe we need to look at the problem differently. Maybe we need to get different groups of people talking and have them come with this sort of open-minded mentality. And that's why I set up BRAIN. And that's where you really start ramping up, altering the trajectory of diseases, not in one domain, but across multiple domains simultaneously. And that's when you really start seeing massive system-level changes occurring. That's
Paul,
what I think.
Let's suppose I had an idea about something is either a device or a treatment. How would I practically approach BRAIN?
Well, the short answer is you contact me.
Good.
The longer answer is you contact me. We have a little conversation about it. Happy to sign NDAs. I know company people, things like this, if there's intellectual property involved. If you're going to come to me, I always say protect yourself first. Then we have a discussion, and then we talk about potentially how we could, if it's possible, how we can partner and have a presentation. But ideally not just a random presentation. One of the things that I found from going to conferences in the last few years was that they didn't really help me to improve my understanding. And the reason is often because the information is not portrayed in a, let's say, a helpful manner. It's one random talk next to another random talk, next to a completely different topic. It's just a sort of weird patchwork quilt of information. And your mind has to somehow construct this into a usable framework, which can be quite difficult for people. And it also means that you're probably far more likely to just leave the conference and go and have a cup of coffee on the beach or wherever it is. So with Brain, what I try to do is to create story arcs. And I try to get the best people explaining their understanding along a different part of that story arc, so that your mind, it's relatively easy for your mind to come out of it thinking, oh, I understand actually a lot more. So for example, I'll give you just a very brief example on one of the story arcs from Brain last year. There was a new company called Magneto, probably named after one of the X-Men, although I can't confirm. This basically uses essentially a solenoid around the end of the catheter to create a magnetic field. And that magnetic field can then attract the clot. The problem is if I just say, here's a catheter that pulls out a clot with a magnet, most people are going to say, yeah, whatever, that's just nonsense. Okay, so what I did was I got a lady, Professor Karen Doyle from Galway. In fact, Sarah Novus worked with her. She's one of the world's experts on clots. And I said, I'd like you to give an update on clots. The different forces, the different constructs, but most importantly, I want you to mention the different electrochemical properties that different clots have. So she started that. That's where the arc begins. The second talk was actually about a company called Sensome, a French company. They have a wire that can detect the different electrical impedance of the clot as it goes past. And it can tell you, because of the first, like we just mentioned, because the different constituents cause a different electrical impedance, it can tell you what type of clot you're dealing with. Some are hard to pull out, some are easy to pull out. Okay, so step one, this is the clot type. Step two, here we can detect the different types of clot because of the electrical impedance. Step three, you bring in Magneto. So at the end of that story arc, you see that actually Magneto can work if you go back to basic principles, and you leave thinking, oh, okay, I understand this, now I know why it works. And you leave thinking, I actually learned something, rather than what often happens at many conferences, which is you're just more confused by the time you leave.
So it's quite interesting, Paul, because if you go to medical conference, you have exactly this feeling. You have a series of interesting presentation, but there isn't a narrative, there is an arc, there isn't a story. Yeah. And I was looking around this expo. I haven't had the opportunity, and I may say something that is wrong, but you have the different booths with things that are quite unrelated, close to each other. So if you are specifically interested in one area, you actually need to travel and look for everyone. Brain, would have probably put all the all the booths of things that are related in one area, and potentially is
one area.
Yeah, is one area, is from the start to the beginning, the antiseptic, the needle, and that it is a really interesting view. Questions so far?
Thanks very much. It's very interesting. I'm just wondering, of your acute stroke patients that you would treat,
Yep.
what percent roughly would have a recurring stroke? And then in terms of kind of post-care monitoring, how good is that system in place? Is there anything we can do better in terms of diagnostic monitoring?
Sure, that's a really interesting question. So, do you mean, it depends on your definition of recurrent stroke, I suppose, because what one definition is a recurrent stroke that requires a repeat mechanical thrombectomy, for example. That's not very common, actually. It's probably less than 5%. I think it's about 2 to 3% of patients. But it's not inconceivable, however, that these people could have much smaller strokes at a later stage. That's probably far more common. And, we'll talk about things like atrial fibrillation, which is the abnormal heartbeat, and putting people on like blood thinners to prevent the stroke. But they don't reduce your risk of a stroke by 100%. They actually, I think some of the more modern, what are called DOACs, direct oral anticoagulants, like the warfarin replacements, let's say, I think if memory serves correctly, they reduce your stroke by about 2/3. So you've still got a reasonable risk of having another stroke, even if you take your tablets like you're supposed to. In terms of monitoring, that's a very interesting question, because I would much prefer not to have to do my procedures, right? I would much prefer to be able to give someone a tablet or a lifestyle change that means they never have a stroke in the first place, right? It sounds bizarre, but I'm a medic, and I have a family and stuff like this, so I'd rather just see everyone be healthy and the world not need doctors, really. But the monitoring is problematic, because how do you monitor someone effectively all the time? You kind of can't. I think Apple, my fiance has what's called an Aura ring, for example. It monitors blood rate, blood pressure, heart rate, all of these things. Like, wearables are coming, but those are still a surrogate. Let's say you're wearing your Apple Watch on your left hand and you have a stroke that affects the right side of your body. How are you going to know about it? Unless you wear two watches. Fair enough, some people do. Are you going to walk around with a helmet all the time? Probably most people won't, So really what you want to know, what I suppose you want to be able to do is identify the high-risk people and then have a system that might be able to identify them, or at least have an early alert that they could trigger or something could trigger. And, maybe care homes and things like this is where you need that kind of early warning system. I'm not advocating for cameras everywhere, but, for example, a camera system, especially with AI, could probably tell this person hasn't moved their right side of their body for the last 30 minutes. They've been sat in a chair, they're slumped, and they haven't moved the right side of their body. Send out an alert to the people in the care home, for example. I think things like that are coming, and probably rightly so. I'm working with a company that's developing a helmet-type technology, not really for that type of arena, but more for... we mentioned that when you have a stroke, you go to your local hospital, and then you go from there, you have your CT scan, then you go from that hospital to the next hospital. Right, that is a huge problem. If you could cut out this middle hospital in its entirety, a 7 to 10 hour journey becomes a 2 to 3 hour journey. So I'm working with a company developing a helmet that we hope will be relatively cheap, will have high sensitivity and high specificity, that can be used in an ambulance, so it becomes like an ECG but for the brain. So maybe a blood test, clinical test obviously, helmet, you've got enough. This person's having a large vessel stroke or medium vessel stroke or what have you. Give them the thrombolysis and just get them straight to a mechanical thrombectomy center. Don't miss this hospital, miss the middle hospital. They can deal with other things, but get them to Paul or one of his colleagues. So there's all of these things that they all come together, let's say. Does that make sense? Has that kind of answered your question? Okay.
Good morning. Great to hear the progress you're making. Just referring back to the other allied health professionals you need, and you talked about radiologists, and it's clear that you've achieved some success there.
Yeah.
But are there risks hidden in other areas like radiography? And just thinking back to something I was listening on the radio on the way in, and cancer, can that impact what you're trying to do because of pressures in other places, and how you resolve those?
Yeah, no, so I completely agree with you. For example, look, I can't make a decision at the moment without having a good quality CT angiogram. So who does the CT angiogram? Well, it's the radiographers. So if the radiographers don't do a good CT angiogram of the head, so a CT angiogram is the dye is injected and it fills the blood vessels. So obviously if there's a sudden block in one of those blood vessels, then you can say, that's where the block is, right, that's what I have to do. And this also feeds back into the AI stuff, because I remember, for example, the AI once called a block. But the timing of the scan was not a CT angiogram, it was a CT venogram. So the input was completely wrong. The AI didn't recognize that it was completely wrong, and then falsely called a block because the appearance looked like it was a block. So hence why I said AI will never replace a person, because I recognize that, my stroke doctors recognize that, but it requires like expertise at every level. And that's the key for medicine and actually many things. If you don't have everyone doing their job well, like the whole system starts to break down. So you have to have conversations, you have to have training. This comes back to partnering with Johnson Johnson, who can help with training events, help, just have like dinners or lunches and things like this where we give presentations. Our radiographers can say, this is how we do it at our site. We had the problems that you had. This is how we negated them. And then you have the general problems that I think you alluded to. Yeah, look, if you only have one CT scanner and you've got 5 trauma patients, 2 of whom are bleeding out, and then a stroke patient who has got some time, what are you going to do? You're going to go through the trauma patients first. You need some redundancy in the system. The NHS doesn't really function on redundancy, as far as I can tell. I'm not quite sure how we can get around that. There are novel ways. I'm not sure if any of you have ever seen this, but there is a company called Hyperfine, which has developed a portable MRI machine. I mean, it's amazing. But not yet in any hospital in the UK. But there's no reason that, the UK is funny. We developed CT scanning technology. We developed MRI technology. And then we don't have the same number of CT or MRIs per capita compared to several of the other OECD countries. So we're great at sort of developing the tech from a university level, but how do we translate that into startups, into clinical use or whatever? It's not even clinical, it's not like it's the only things that we developed in the UK, but we don't then take full advantage of. And I think that's also, a sort of bigger picture here. We need to invest not just in the initial research stuff, but in the translating it into, here's a startup, this turns into my unicorn. The US is fantastic at that, and the UK should be actually really good, but we're not. I'm not quite sure why. But I think those are other discussions to be had. But yeah.
Yeah, so UK tends to be really good at piloting stuff and not really good at implementing on large scale. So and that affects pretty much all the medtech sector and is well recognized issue. Right. What other areas would you like us to go a little bit deeper in? What is the thing that tickled your imagination or your interest more?
Hi. Yes, maybe about predicting stroke and how we can follow people
more closely
to find those high-risk people before it gets to the point of view.
Yeah.
So, for example, with long COVID, they're seeing the microclots. Is there anything going on there that leads to stroke? So what can you suggest that people should be looking at?
Well, I think the basic stuff, really, the long COVID and the microclot stuff's interesting. Actually, I published on this a few years ago. For me, a lot of these things are, again, in the UK, sometimes you're a little bit stuck, right? Because we don't seem to implement the latest evidence fast enough. So, for example, a classic here is, we'll talk about the hardening of the arteries, atheromatous disease. And we are still a little bit stuck looking at just the degree of the stenosis. But we know now very well, there's plenty of evidence for this, maybe not on RCT, but plenty of observational and longitudinal evidence that suggests it's not just the degree of stenosis, it's the constituent of the plaque. A very fat plaque, very eccentric, very eroded, that is far more likely to send off little clots, even if it's 50% stenosed or 20% stenosed, than a 70% very smooth, very fibrous plaque. Yet the only thing we talk about is the degree of stenosis. It's sort of a bit dumb, But the reason that we do that is because we don't have access in most centers to do plaque MRI. Why don't we have access to do plaque MRI? Because we don't have enough MRI scanners. So how are we ever going to get to a point where we're doing the most advanced imaging in order to determine which patients should get treatment and which patients shouldn't, when we don't even have the baseline infrastructure? But I don't want to make it sound negative, because in truth, wherever there's a sort of a problem, there's also an opportunity. And so the fact that we don't have MRI doesn't mean that we can't maybe start looking at a different type of imaging modality. Or rather than saying, well, plaque MRI takes 45 minutes, okay, fine. Well, maybe we should talk to the MRI physicists around the country and say, this is what I need to see. Can we work on making a faster protocol? Something that takes 5 minutes, for example. So wherever there's a problem, there's nearly always a solution. We just have to get those people together to say, how do we solve this problem? You know? That's the beauty of kind of struggling a little bit in the NHS. And that's where the interesting stuff happens, because that's where your startups come from. That's where your spin-outs come from. That's, in my opinion, anyway.
It is possible to identify higher risk individuals. Sometimes the resources that we know now can identify these high risk individuals are expensive or not available or long. It doesn't mean that we can't do it in a different way. And there are, if you look at the history of medicine and the most recent one, there are many things that we were doing one way in a really complex way, and now we have a new system that allows us to do it in a much faster way. So, and surgery from big incisions to minimal invasive, the robotics, the single. So, and every single time there is an opportunity for somebody that has an idea and the will, and is put in a context where is he a startup incubator and is a collaboration with a company. And yes, I like where there is a problem, there is an opportunity. Is that you need somebody that is engaging the brain and find the energy to move it forward.
Hiya. I was wondering, you've talked about the processes around the mechanical thrombectomy, but during the actual surgery itself, where do you see any issues or complications that happen in the surgery, and where do you think the biggest area for gains are in there as well?
That's a good question. So there's the biggest, this is a very sort of broad question, and I could literally talk for like 3 hours on this topic. But the one that I think will offer let's say the biggest bang for your buck at the moment is a disease called intracranial atherosclerosis. Okay? Intracranial atherosclerosis is this hardening of the arteries that I've just described here, but it occurs intracranially, obviously, right? Now, this is interesting because this disease affects let's say about 10% of Caucasian people, but it can affect up to 50-60% of non-white people. So as you see the changes in demographics, not just in the UK, in Europe, but also around the world, this is actually the #1 cause of stroke in the world, intracranial atherosclerosis. I actually have my own startup looking at this. I'm a co-founder of a company looking at this particular disease, because we don't have very good equipment to deal with this. In fact, the equipment that we do use, we've kind of bastardized it from cardiac and things like this, right? But it's not optimized for that. The heart and the brain are, despite what the cardiologists might say, very, very, very different organs, and the pathologies and even the blood vessels are different. They're not the same. So that's one of the areas that I think actually offers the most, because when you have that problem, you'll often have a bit of a plaque that forms on it, an acute thrombus. You remove the acute thrombus, but the problem is if you just wait 5 minutes, the thrombus comes back again. So the vessel kind of opens and then it blocks again. Then it opens and it blocks again. And coming back to prediction, if you look, for example, at intracranial atherosclerosis and dementia, people who've got a confirmed diagnosis of dementia but also have intracranial atherosclerosis, their prognosis of decay is much faster their disease severity, it progresses so much faster, even if it's not a significant stenosis. So we aren't looking at this cohort of people. We should be looking at them saying, hang on, is this because of hypoperfusion, low perfusion to the brain, and that's actually feeding back into the underlying dementing process? So what if we restore the blood flow? Well, that actually might slow the process of the dementia, keep people in their own homes, etc., etc. So you might say, oh, it's an invasive test, it's an invasive procedure, but if it keeps that person in their own home, they don't have to sell their house, etc., to pay for their care. Well, isn't that a good thing? Isn't it better for the economy, better for society? So there's all these sorts of things, and you only get this sort of, I don't know, like, these questions are very interesting because this is exactly why I set up Brain, to start sort of probing and poking a little bit on the edges of where we are at the moment, but where we're going in the next 5 to 10 years. How do you get there? By having these conversations and putting a bunch of people together who normally wouldn't talk to one another.
So it is fascinating because we started from a very pragmatic point, say stroke, there is pathway, there are multiple interconnected elements that need to learn from every industry, so it's process optimization. And then we look at, you know, the question about what is the opportunity to improve a procedure. We step back and we say, actually, there are fantastic opportunity to improve quality of life. If you look at our lifespan is increasing, so things that were not really appearing because we were dying younger now become more and more prevalent. So dementia is one, interrelationship with atherosclerosis is another one. And in my head is that are all the big challenges that require clinicians to work with industry, and industry is there are the big one. J&J is one of those, but then there are the 1 in 100 million startups with people that really passionate, that look, okay, I'm really fascinated by this problem, and our big problem that can only be solved together. So no single individual, no single profession. It's a clinician alone, they need engineer, the engineer, they need, and so it's fascinating, and I see huge opportunity in the medtech sector. And I think on this topic, we have reached the end of our hour. I'm really grateful to have seen you here and sitting here. Probably they were the only chairs available, so they said we have a little dose before starting the day. Really, really grateful. Thank you so much, and enjoy the expo.
Thanks very much.